COVID-19 isn't the only infectious disease we have to worry about. Infection preventionists certainly know that. They know that about 72,000 Americans die of healthcare acquired infections each year, and they can be anything from the fairly recent Candida auris to the seemingly ubiquitous C. diff to the flu, whose lethality should never be underestimated. Hi, I'm Frank Diamond, the managing editor of Infection Control Today. We try to give infection preventionists and other healthcare professionals the information they need to battle COVID-19 and many, many other dangerous pathogens. They haven't gone on vacation, those pathogens. My guest today is Sylvia Garcia-Houchins. She's the Director of Infection Prevention and Control for the Joint Commission. Ms. Garcia-Houchins has over 30 years of experience in infection control in both the hospital and long-term care settings. Her specialty areas of interest include disinfection and sterilization, dialysis, and infection prevention during renovation and construction. She has an extensive background. Google her, you'll see. Ms. Garcia-Houchins, thanks for visiting us here today at Infection Control Today.
Thank you, Frank, and thanks for the opportunity to speak to your audience today.
Now, one of the key functions of infection prevention and control programs is overseeing and following up on healthcare-acquired infections. But with the COVID pandemic going on for months and knowing that it might be some time before you get a vaccine, a long-sought vaccine, some are concerned about how COVID has affected the day-to-day operations and resources of many infection control programs. And as an example, the CDC has eased their recommendations for isolation of patients with certain multi-drug resistant organisms because of shortages in personal protective equipment and other shortages. How are infection preventionists managing the oversight and prevention of healthcare-acquired infections these days?
So it's really interesting. We've been hearing a lot of different things depending on where in the country the person is, what's the level of transmission that's happening. I think initially everybody did oh my gosh, we have a pandemic happening. It's sort of a dead stop everywhere. And we got to get ready. We've got to be prepared. We need to get everything lined up. And so I started thinking about what was going to happen. Many organizations at that point, the IP was really put into a position, put my resources here, I'll put my resources there. I need to get us a plan. I need to make sure we're ready. So that initial part, some people didn't have the backup support to just do the routine stuff that we would normally do to manage hospital-acquired infections. So the rest of their stuff, just like what happened with Ebola, got put on hold. As this pandemic has played out, some areas have now gone pretty much low-level transmission. Things are operating well, sort of on the back burner. We're ready. PPE is stabilizing. We've got a process to make sure that it's still there and it's coming regularly and anticipating, right? Other organizations still are in that flight or fright part, which is that adrenaline rush is still on. They're seeing cases, they're seeing increases, what's happening today. And those are really the organizations that are struggling. Mm-hmm. Day-to-day operations is not happening. And so they may not have the resources to look at those other health care associated infections. And we're hearing reports of this in our Office of Quality and Patient Safety. You know, we're starting to hear, I don't have the right gown to go into an isolation room. Right. Or this isn't a COVID patient, it's a patient with an MDRO, and they're asking me to put on gloves, but we don't have gowns. They're asking me to preserve the gowns for something else. It's really a struggle. IPs need to have good resources and good references to make those judgment calls on what it is they're doing day to day. I mean, that really has changed with the CDC stuff.
But the reality is they haven't had the resources they need recently. I mean, maybe it's gotten better the last couple months. In the beginning, certainly they didn't have the resources they needed. Yeah. And it was kind of crazy in some places with overflowing emergency rooms, and COVID was the problem. But again, in the meantime, healthcare acquired infections continue. And they continue sometimes with COVID, right?
Yeah, we actually heard of little clusters or outbreaks that were happening at organizations where they had set up cohort units for COVID, right? So I'll put all the COVID patients together and wear the same PPE, the same gown and gloves because you don't have enough between multiple patients, where normally we would have someone with Candida auris or a resistant Acinetobacter. And we'd be being very careful as IPs to make sure our staff knew, take off the PPE, do hand hygiene, put on new PPE for the next patient in the cohort. That wasn't possible.
Yeah.
So we were hearing about clusters of infection. The other thing that happened is, initially staff were scared. Priorities may have changed a little bit. We need to save this person's life. We need to protect our staff from being exposed. And so some of those routine things that we would have probably done for a patient, for example, on a ventilator, routine oral care, keeping the head of the bed up, right? Pulmonary toileting for someone who's starting to walk and get better may not have been done because of limited PPE or just overwhelming number of patients. So those routine practices may not have been possible for a time, and still may not be possible in some organizations. So, that's the real hard part, is keeping a handle on that, making sure that people know, yeah, COVID's important, but if they end up with a ventilator-associated pneumonia, that could kill them too. They're really important. So as we talk about regulation and requirements, right, we need to think about what's a requirement, meaning there's legislation that says you must do, versus a recommendation or guidance. So CMS is an example of an organization that puts out regulation, right? And so if they say this is a regulation and it is a requirement, keyword requirement, then organizations have to do it. If they put out information that says this is guidance or a recommendation, then there's that gray area. Do you have to do it or do I not have to do it?
Right.
That's caused some real issues here during this pandemic, because some things that everybody thought were requirements aren't actually requirements. And some of the things that people thought were recommendations that they could have some leeway on are now coming to light, and people are saying, well, depending on what state you're in, it's now a requirement. No, so we don't actually grade hospital performance. So we're an accrediting organization.
Right.
So as an accrediting organization, we go into organizations who may be deemed, meaning that we are surveying for compliance on behalf of CMS, or they may not be deemed, which means they've invited us in to help them to ensure they're providing the best quality of care for their patients. So we're not a regulatory agency. I think that's an important part to start with. Right. We are an accrediting organization.
Right. But you also made healthcare acquired infections a priority around the same time. Yes.
Yes, we did, and we actually this year have changed. It used to be national patient safety goals to reduce certain particular hospital-associated infections, but we weren't prescriptive. We said you need to look at the guidance and you need to put in processes in place to implement those best practices and recommendations that are applicable to your care and services and settings. And so we don't do a one size fits all.
So I guess that segues into my next question. Has the Joint Commission, in light of COVID, altered or adjusted their approach to accreditation regarding healthcare acquired infections?
Nope. We're still doing the same things. We're still expecting organizations to continue to follow those practices to reduce healthcare associated infections. That has remained throughout this pandemic. Now, how organizations do that? For example, if we go into an organization and the organization's policy and procedures say that the nurse should perform oral care every 4 hours, and we go and we see they're not doing it, right? So they're not in compliance with their own policy and best practices to reduce ventilator-associated pneumonia. We're going to start pulling that thread. Why aren't you doing this? Now, there's a lot of reasons today why they might not be doing it. One of the key reasons may be because they can't get the supplies. If they can show us, look, we're trying, but we can't get the supplies, and instead we're doing X to try to mitigate that risk, we would consider them in compliance. Now, if they've got a policy in place, they're supposed to be doing every 4-hour oral care, and the person or just says, well, I don't have time to do this, we're going to start pulling that thread. What's the issue here? So we really do, for those things, survey to what practices have they put in place? What practices have organizations put in place to reduce the risk of healthcare-associated infection? And are they implementing them? Regardless of the pandemic, are they implementing them? If they can't implement them, that's one thing. Right? They don't have the supplies or the equipment. How have they modified those practices to try to reduce that risk? Versus they're just not doing them. And remember, if we're going out to survey, that organization has told us they are ready for survey.
I see. Have been surveying less since the pandemic struck?
So we have been surveying less. For a while. We had to put a stop on on-site surveys while this was all sorting out. Many of our organizations just couldn't handle being ready for the pandemic. You know, their emergency response plans were being activated. We could not risk distracting them from that important task. As things have leveled out and we're seeing, you know, decreased outbreaks or clusters of COVID, and the prevalence is going down in some areas, we've now got criteria for when we will have our surveyors go out. We work with those organizations to say, are you still operating under your emergency management plan? Are you ready for a survey? Can we come out? We don't want to distract from their ability to care for patients. So if they say, yep, we're ready, and they're considered, we have criteria for what level of transmission there can be in the community, because we want to protect our surveyors too. If they meet certain criteria, then we can schedule a survey. They are still unannounced surveys, but you know, we're proactively going through what's on our list in the next 3 months, who's up for survey. We're trying to get rid of the backlog and look at, you know, as areas get safer, and that's, you know, a relative term, but as they have less COVID, we're looking at that. But we did stop survey for a while. We are now back up in surveying. We're doing a lot less surveys right now just because people aren't ready, or there's significant transmission occurring in the community. So what might work at my organization from an evidence-based guideline may be different at another person's organization. It may not work. So that's the part that organizations get to choose. We look at that. We say, huh, what are you doing? That looks like you made some good choices. Show us how you've implemented it. Show us how it's affected your infection rates, right? Your CLABSI rate was at 2, it's now at 0.5. CLABSIs per 1,000 central line days. Wow, you're doing well. Or you were at 0.5 and now you're at 3. So what are you doing about it? It's not supposed to be confrontational. It's not supposed to be, we're not inspectors, right? I think that's important.
Any final words for your fellow infection preventionists who are dealing with healthcare acquired infections and COVID-19 and waiting for the second wave of COVID-19 and possibly COVID-19 like other pathogens will come in waves? Any final words of advice for them?
Yeah, don't lose sight of the overarching point, which is all healthcare associated infections are important. We want to prevent morbidity and mortality of all of our patients. So we need to make sure that we've got processes in place that look at everything, right? Sometimes we get focused on one thing and making it perfect, and we don't look at everything else. So we need to have that eye on the ball. The goal is decrease all healthcare associated infections, not just one.
Sylvia Garcia-Houchins, thank you so much for visiting Infection Control today.
Thank you for the invitation again.